All right. Well, thank you, and thank the organizers for inviting me to speak today. So I'm going to talk about the incretins and their effect on cardiac structure and function. We're learning more about this. It's a very new area, so more to come. So I'm going to be talking mostly about the role of incretins, GLP-1 receptor agonists, primarily in HFpEF and how they affect cardiac structure and function. But there's more data in diabetes than there is in heart failure at this point. So I'll be talking about their effect in diabetes. But let's start by talking about how obesity affects the cardiovascular system. So obesity leads to expansion and biologic transformation of visceral fat, including fat around the heart. That leads to altered synthesis of adipocytokines. Adipocytokines then have anti-natriuretic effects that lead to sodium retention and plasma volume expansion. And together, those lead to increased filling of the left ventricle. In addition to those anti-natriuretic effects, the adipocytokines have pro-inflammatory effects. So the pericardiac fat expansion leads to myocardial inflammation, injury, and fibrosis, and may lead to increased LV mass as another effect. And all of these effects lead to the reduced ability of the LV to tolerate increased filling. So reduced relaxation, diastolic dysfunction. So the combination of increased volumes and inability to tolerate those increased volumes lead to the clinical presentation of heart failure with preserved ejection fraction. So there are a number of therapies for obesity, as you're aware. This is from a nice review this year in JACC Heart Failure. There are lifestyle interventions that have that certainly work in terms of diet and exercise in some patients. There are medications such as the semaglutide, GLP-1 receptor antagonist that was associated with 18% reduction in heart failure composite endpoints with 2-week therapy. Surgery, bariatric surgery. We know that bariatric surgery can reduce heart failure. And there's increasing evidence in heart failure with preserved ejection fraction over and above that with reduced ejection fraction. So the SECRET trial was a hypocaloric diet plus exercise, led to 10% weight loss at 20 weeks in HFpEF population. We know that drugs can work. That was based on the STEP HFpEF trial that was published last year in the New England Journal with semaglutide. There was 10.7% weight loss at 1 year, as well as improved symptoms and functional capacity in a group of patients with HFpEF. And lastly, there was a non-randomized study of bariatric surgery published in 2021, propensity match cohort, with a 57% reduction in mortality, 67% reduction in heart failure hospitalizations at nearly 5 years. Now, remember that this is a non-randomized study. In HFrEF, there's less data. There are no current HFrEF studies of the anti-obesity medications. So how did GLP-1 receptor agonists work in various systems? So they are vasodilators, so blood pressure can fall. They work on the gastrointestinal tract to reduce gastric emptying, reduce chylomicron secretion, and in the GI tract, they have a number of their adverse events: nausea, vomiting, diarrhea, gallbladder disorders. They work on the pancreas to increase insulin and somatostatin release, and also decreasing glucose and glucagon release. and they act centrally on the brain to reduce appetite. And all of these then lead to reduced adiposity, reduced body weight, and in turn, reduced inflammation. So these drugs have been studied well in diabetes. And when this is a review in Nature Review Cardiology last year that summarized the data. Essentially, they reduced non-fatal MI, reduced cardiovascular death, reduced non-fatal stroke, and in summary, improved cardiovascular outcomes compared to standard of care in diabetes. So what about cardiac structure and function? So we have data in diabetes. We have a little bit of data in HFpEF, but in diabetes we have a fair amount of data. This is a meta-analysis published earlier this year from 15, putting together 15 trials, almost 900 patients. There's a slight reduction in LV mass that just met statistical significance, only about 3 or 4 grams reduction in LV mass in diabetes with GLP-1 receptor antagonism. There's no change in LV global longitudinal strain. There's a trend, but doesn't reach statistical significance, to a drop in LV end diastolic volume. So reverses what I spoke to earlier of the increase in volumes in HFpEF. There's no change in LV end systolic volume when looking at these studies in toto. There's no change in LV ejection fraction. There's no change in E to A ratio. The most powerful effect in diabetes is a reduction in left atrial volume, and we'll come back to that in HFpEF. So this was the mean reduction in LA volume in this meta-analysis was about 8 cc's. So in summary, in diabetes, a slight reduction in LV mass, a trend to reduction in end diastolic volume, and a reduction, significant reduction in left atrial volume. So how about in HFpEF? Well, just this year in JACC, Scott Solomon and colleagues published this paper on the echocardiographic substudy of STEF HFpEF. Just a reminder, STEF HFpEF was a study of semaglutide in obesity-related heart failure. So almost 500 patients with symptomatic heart failure, EF more than 50%, BMI more than 30, randomized to once weekly semaglutide or matching placebo. The pre-specified primary endpoint was change in LA volume based on the data in diabetes. Resting echo was performed at baseline and then at 52 weeks. And what the principal finding in terms of the primary endpoint was not a reduction in LA volume, but a reduction in the progression of LA volume in the treated group. So in the treated group over a year, increased LA volume by 7 cc's compared to 13 in the placebo group, and that difference was highly statistically significant. Those benefits were consistent irrespective of multiple baseline characteristics. So across the board, a reduction in LA volume. They also improved E-wave velocity, E to A ratio, E over E prime, and RV remodeling. So there was a benefit on diastolic function, but there was no effect on LV mass, LV mechanics, or LA strain. So one of the problems here is that measuring changes in LV mass by echo, as we know, is problematic just because it's a 2D estimate of LV mass essentially based on wall thickness in the parasternal long axis view. So the power to show changes in LV mass on a 2D echo study is modest at best. So the other notable finding here was the linear relationship between the change in body weight and the placebo-adjusted change in left atrial volume from baseline. So you can see as body weight declined, left atrial volume fell. However, the benefits of semaglutide on all of the parameters of diastolic function and RV size were not associated with weight change. So really, it was LA volume alone that had this association with weight loss. So we've talked about cardiac structure. What about epicardial adipose tissue? As I introduced this topic as saying that the adipocytes and the adipocytokines are very important in LV remodeling cardiac remodeling in HFpEF. Well, this is a meta-analysis of 18 studies over 1,000 patients with epicardial adipose tissue measured in a heterogeneous way in these studies, some by CT, some by ultrasound, some by MRI, and compared studies of GLP-1 agonists, SGLT2 inhibitors, and statins. And the GLP, in terms of reduction in EAT, GLP-1 agonists were the most potent, followed by SGLT2 inhibitors, and statins were fairly weak at reducing epicardial adipose tissue. So keep that in mind in terms of the effect of these various agents on this important contributor to cardiac remodeling in HFpEF and diabetes. There is one small study in the literature on GLP-1 RA and epicardial adipose tissue in patients with coronary disease. This is a letter published in JACC just a few months ago, 115 diabetics as a sub-study of a atherosclerosis progression trial of semaglutide. In this sub-study, 58 treated, 57 placebo, followed for 12 months. The semaglutide group is in red, the placebo group in blue. You can see there's a decline in EAT in the treated group, whereas there's a slight increase in the placebo group, and that the difference over time was highly statistically significant. So semaglutide was associated with a reduction in EAT over a year, and one can measure EAT density with CT, and there was a decline in the density of epicardial adipose tissue by CT in the treated group as compared to placebo. So now, in the last part of the talk, turn to a discussion of tirzepatide, which, as you know, is a combined receptor agonist. It's a long-acting GIP receptor and GLP-1 receptor agonist. So different characteristics than the other pure GLP-1 receptor agonists on the market. So it's associated with weight loss, as shown in the SURMOUNT study in New England Journal 2 years ago. At the higher doses, 10 milligrams to 15 milligrams over 72 weeks, was associated with between 21 and 25% reduction in body weight. So more potent than some of the GLP-1 agonists alone. So I'm going to tell you about some of the baseline entry criteria to the SUMMIT trial, but I can't give you any results because there's going to be 4 presentations at the American Heart meetings in Chicago next week and 4 simultaneous publications in a number of journals on the results of the SUMMIT trial. So what is the SUMMIT trial? The SUMMIT trial is a randomized placebo-controlled trial of tirzepatide in obesity-related heart failure. Entry criteria were men or women older than 40 with a diagnosis of HFpEF, EF more than 50, BMI more than 30. They also had to have enlarged left atrium, elevated LV filling pressures, or BNP more than 200 in sinus rhythm or more than 600 in AFib. To enrich the population for a sicker population, required a 6-minute walk distance less than 425 meters, a KCCQ summary score of less than or equal to 80, and either a heart failure decompensation within 12 months or some renal disease with an eGFR less than 70. Patients were screened and then randomized to either placebo or tirzepatide. Starting dose 2.5 milligrams per week, increasing by the same dose every 4 weeks to a maximum dose of 15 milligrams per week by week 20. And then they were followed for up to 104 weeks in blinded fashion. The primary endpoints were actually changed blindedly during the course of the study based on the STEP HFpEF results, which came out during the study. And the final primary endpoints were cardiovascular death or worsening heart failure events, as well as KCCQ scores at 52 weeks, with a hypothesis that there would be 20 to 30% risk reduction. As I said, the outcome study will be presented as the second late-breaking clinical trial in the opening session of the AHA next week from today. I was fortunate enough to be the PI of the CMR sub-study of Summit, which we recruited 175 patients, primarily from Latin American countries. These were not centers that were necessarily expert in CMR, and for that reason, there were some dropouts because of image completeness and image quality. We ended up with 106 patients, 50 in the treated group, 56 in the placebo that completed baseline imaging and imaging at 52 weeks. We performed short axis imaging, such as the one on the right, starting from the apex all the way to the posterior wall of the left atrium without any skips, so back-to-back slices. The primary endpoint for the study was between group changes in LV mass. Other endpoints included epicardial and pericardial, and their sum, which we termed pericardiac adipose tissue, as well as LV and LA structure and function. Let me just point out the components of the pericardiac fat. So first of all, on the short axis, the red arrow points to the pericardium. Here's the pericardium here. Epicardial fat is the green arrow. It's that smaller amount of fat sitting right on the epicardial surface between the heart and the pericardium. That's it here. And the pericardial fat is this markedly increased amount of fat outside the pericardium. So this is visceral fat. In fact, in the study, there was 4 times as much pericardial fat as epicardial fat. There, in these obese patients with HFpEF, there is a modest amount of epicardial fat. There is much, much more epicardial fat or visceral fat. Again, I can't share the results. I'll be presenting the results of the study on Monday afternoon in a featured science session at the AHA in Chicago next week. This will be simultaneously published in JACC. Thank you, Dr. Krumholtz, and look forward to seeing it there. So, in summary, what we have learned about GLP-1 receptor agonists plus GIP receptor agonists is that we're learning more. For GLP, I can't share with you the combined results, but for GLP-1 receptor antagonists, they clearly in HFpEF reduce left atrial volume, improve diastolic function, RV remodeling, and we'll learn much more about tirzepatide and its effect on cardiac structure and function next week at the AHA and in JACC and in the New England Journal. And with that, I'll end, and thank you for your attention.